Welcome to the concept of gas exchange and oxygenation. This is probably one of the most integral physiological processes that you are going to learn about. This is your pre-assignment. You need to review this PowerPoint and read the assigned pages in Yoast and Giddens. And make sure that you look at these YouTube videos when they come up in the PowerPoint. You will have a quiz in the morning over this pre-assignment. These are the learning objectives for this topic, and here are your key points. The key points are basic concepts that you should have an understanding of. Your first learning objective is to define and describe the concept. So if you don't have the concept map in front of you now, go get it, because we're going to go over it, and this first slide is the definition of the concept. The process by which oxygen is transported to cells and carbon dioxide is transported from the cells. Within this definition, we have the idea of inspiration, moving air with O2 into the alveoli, and expiration, moving air with CO2 out of the lungs. The antecedents include the systems that need to remain functional for optimal gas exchange to occur. This includes obviously the respiratory system, but also the neurological and cardiovascular systems. If these are functional, the patient will have positive consequences, and if not, then negative consequences. Hopefully you have been introduced to the nursing process by now. But what I want to show you is that your interventions will all be directed towards strengthening the systems that are included as antecedents. So with gas exchange, we will be strengthening the respiratory, neurological, cardiovascular systems, whichever areas are causing the problems. Here we have the attributes, or what must occur in order to see positive consequences. When we assess our patients, we will be looking for these attributes to all be within normal limits. That includes respiratory rate, ABGs, level of consciousness, and skin color should all be within normal parameters. When attributes are within normal limits, we will see positive consequences, and if not, we will assess negative consequences. Next, we have our interrelated concepts of mobility, coping, acid-base, perfusion, and nutrition. Gas exchange can be affected by these, as well as these interrelated concepts can be affected by gas exchange. For example, the postoperative patient on bed rest can more easily develop pneumonia than one that is up ambulating in the halls. These are considered sub-concepts: inhalation and exhalation, oxygen carrying capacity, and circulation. All are critical components of gas exchange. Impaired ventilation can be a result of a variety of issues, such as head injury, oversedation, lack of surfactant in newborns, and many disease processes, each affecting inhalation and exhalation. Impaired O2 carrying capacity can occur with anemias that result in low H&Hs, low RBCs, blood loss, or anything that diminishes the O2-CO2 transport in the system. And finally, impaired circulation or perfusion will occur with decreased cardiac output or peripheral vascular disease. Ischemia and cell death can occur whenever any of these processes are hindered, and if CO2 can't make its way from the cells, respiratory acidosis will occur. So now we're going to look at the respiratory system as an area to strengthen if in our assessment we have seen some negative consequences. There are only 4 components of the pulmonary system to consider, and these are the bronchi and bronchioles, the airways, the alveoli or the air sacs, the pulmonary capillary bed that surrounds each alveoli, and the interstitium, which is a connective tissue that holds it all together. Any impairment in one or more of these will affect gas exchange. The next system that may need to be strengthened is the cardiovascular system, which includes not only the heart and lung transfer of O2, but also the delivery of O2-rich blood throughout the body. Impairment can occur with peripheral vascular disease or with congestive heart failure, where a weak pumping heart cannot propel the blood forward as it should, so it backs up into the heart, causing cardiomegaly, which is an enlarged heart, and into the lungs, causing pulmonary edema, which we might hear as crackles. Look at the YouTube on this slide. It shows you that we must have functioning RBCs with adequate iron and globulin to have optimal gas exchange. Red blood cells can fold to go through the tiniest capillaries as long as there's not peripheral vascular disease. This slide shows that each hemoglobin molecule carries 4 iron atoms that attract and transport the O2 to the cells, where the globulin part of the molecule attracts and carries the CO2 back to the lungs. So any problems with this RBC, like an iron deficient diet, can affect gas exchange. Now, with each RBC containing 14 billion hemoglobin molecules, that should be a lot of O2 being moved around. But what happens is that only 3% of the O2 is dissolved in the blood and accessible for use. The other 97% is tightly bound on the hemoglobin molecule and is called oxyhemoglobin. Acidosis loosens this bond. So when a patient goes into cardiac arrest and becomes acidotic, the bonds loosen and the O2 moves from the hemoglobin molecule into the cells. This is why it's so important to do chest compressions to move the blood around in cardiac arrest, and why we have about 5 to 10 minutes to do so before we have an anoxic injury to the brain. This figure traces the steps in the process of gas exchange. Right in the middle you will see cellular metabolism. So how do you know cellular metabolism is occurring, say, in the person in cardiac arrest? Well, the way you know is by this end-tidal CO2 detector, whether the continuous or the one-time use device. If we are putting in O2 and getting out O2, nothing good is happening inside at the cellular level. But if we put in oxygen and get out carbon dioxide, then we know the cells are breathing in the O2 and excreting the CO2, which is good. This slide shows that gas exchange is on a spectrum of optimal to impaired to absent, with many disease processes in the middle. This is a review slide of what we've just gone over, so you need to read it. Our next objective is to look at populations at risk as well as individual risk factors. Populations at greatest risk are infants, young children, and older adults. The infants have a fetal hemoglobin that predictably will result in a physiologic anemia at about 2 to 3 months of age. The fetal hemoglobin dies quicker, and their immature livers cannot effectively process the old RBCs, so initially many babies become jaundiced with high bilirubin levels. They also use up their stores of iron at about 6 months. They have very small airways, which are easily occluded. All of these factors lead them to be at high risk for impaired gas exchange. In children, the alveoli increase in number from 20 million to 200 million by 3 years of age. Also, lung surface area increases until they're about 8 years old. Older adults, their risks are that they have stiffer chest walls with loss of elastic recoil. They have weaker respiratory muscles, causing ineffective coughing, and they can have dilated alveoli, decreased surface area, and decreased pulmonary capillary networks. These are all expected findings with the aged, but they make these populations more susceptible to pulmonary complications. Individual risk factors include smoking, which is the most preventable cause of impaired gas exchange. There are many chronic conditions that are listed and can result in impaired gas exchange. Immunosuppression from cancer or chemotherapy prevents the body's ability to fight infection. Neurologic alterations can increase the patient's risks for aspiration, and prolonged immobility decreases lung expansion and creates the risk for atelectasis and infection. As we seek to help our patients, a priority for us is to encourage primary prevention, which are measures to promote health and prevent disease. So for gas exchange, this would include smoking cessation, infection control, immunizations like the flu, pneumonia, and now pertussis is being recommended, avoiding post-operative complications like pneumonia and DVT. These are all primary prevention measures. Secondary prevention includes screening and early diagnosis of existing health problems. The third learning objective is to recognize when our patients have compromised gas exchange, or to put it another way, to recognize abnormal signs and symptoms. So we look at our patient's skin color, level of consciousness, and ABGs. On our ABGs, the PaCO2, which means partial pressure of carbon dioxide in the blood, reflects ventilation. If a patient has bradypnea, they are not breathing fast enough, so their CO2 levels will go up. The normal CO2 is 35 to 45, and 50 is considered a critical or dangerous value. A high number results in respiratory acidosis. On the other hand, if a patient has tachypnea, they are breathing too fast and blowing off too much CO2 so that their levels will be low, which can result in a respiratory alkalosis. The bicarb, or HCO3, is regulated by the kidneys and will try to stabilize the pH or acidity of the blood. The PaO2 reflects oxygen transfer at the capillary alveolar level, and the SaO2 is what we correlate with the SpO2, which is our pulse oximetry. This is where 90% is a critical value. So if a patient with lung problems has an SaO2 or SpO2 of 88 and has PRN or supplemental oxygen ordered, what would you do? This slide defines what the negative consequences look like. Abnormal respiratory rate and work of breathing, skin color being either pale, cyanotic, dusty, or mottled, level of consciousness being restless, agitated, confused, or drowsy, then all of our abnormal breath sounds, wheezing, crackles, rhonchi, or stridor. All of these are signs of an acute problem that may need to be dealt with emergently. Clubbing in a barrel chest occurs over time and indicates long-term issues with gas exchange and oxygenation. You can see the abnormal nail bed compared to the normal on this slide. The barrel chest has a 1-to-1 antero-posterior diameter that is caused by hyperinflated alveoli, and certainly it occurs over a long period of time. Learning Objective 4 includes the nursing process of assessment, problem identification, planning, interventions, and evaluation. So as we start with our assessment, this can be as a nurse practitioner doing an annual well patient visit, or at the bedside as you do your initial assessment and check the chart for the history. A problem-based assessment means that you don't do a head-to-toe assessment, but you do a focused assessment on an acute problem area. For gas exchange, you might ask questions such as having a cough, being short of breath, or having chest pain while breathing, or you might go straight to getting vital signs and starting the patient on O2 before you ask any more questions. It all depends upon your assessment of that patient and their immediate needs. If your patient has increased work of breathing, or is diaphoretic, or has obvious bleeding, you take care of the immediate need at hand with the prioritization of ABC, airway, breathing, circulation. Some of the immediate stabilizing nursing interventions are to position the patient with impaired gas exchange with the head of bed up. Sometimes they feel more comfortable leaning over a table with a pillow to support their chest. You also need to put the appropriate O2 and delivery device on them and administer handheld nebulizers if ordered. After the patient is stable, diagnostic tests can be run like ABGs, sputum cultures, and a CBC, which can assess for infections or anemias. Radiology studies, such as a chest x-ray, which can show a pneumothorax, atelectasis, pneumonia, and a variety of other ailments may be ordered, or other diagnostic scans, such as a CT, VQ, or PET scan, may also be ordered. Skin tests such as TB can be indicated as well, and possibly doing pulmonary function tests. Important non-invasive nursing interventions are listed here. Helping the patient to cough by huffing or splinting the chest with a pillow to help them to cough effectively. Teaching pursed lip breathing or diaphragmatic breathing. Using the incentive spirometer or encouraging the patient to turn, cough, deep breathe or ambulate, which is even better. Of course, we want to encourage smoking cessation and address any nutritional issues if present. So what nursing intervention is called for if your patient has shortness of breath with ambulation and you have PRN orders for O2? Do you give them encouragement or do you give them oxygen? In general, if a patient has crackles, they need a diuretic. Coughing will not help that. If wheezing, they need a handheld nebulizer. For stridor, they need racemic epi as a handheld nebulizer. For diminished breath sounds or rhonchi, we encourage incentive spirometer, coughing, deep breathing, and maybe a handheld nebulizer. So for each symptom, there is usually a specific intervention that is best to be done. For special situations, postural drainage and chest physiotherapy can be used to loosen and move secretions. This would be contraindicated, however, with a COPD and or congestive heart failure patient. Someone who needs to sleep on 3 pillows in order to breathe, which is called orthopnea, would not tolerate being turned upside down like that. It is frequently used for cystic fibrosis patients and others who can tolerate it. Invasive procedures are listed, and I have some good YouTubes that you'll want to view, especially for the thoracentesis. Remember that all invasive procedures require a consent form to be signed, and it is a nurse's responsibility to make sure that it is signed and that the patient understands what is going to happen to them. We also are there to teach them about postoperative complications and what to expect postoperatively when they come back to us. The bronchoscopy is explained on this slide, and you have a YouTube address to view about it on this slide. An important concept with any procedure that goes down the throat is that the patient may have an impaired swallow reflex and will be NPO until tested to see if they have an adequate gag response prior to eating or drinking anything. Another invasive procedure is the placement of a chest tube, and there is a video to help you understand some of the risks involved in that. Chest tubes are placed within the pleural space to remove blood, pus, or air, and we will be going over chest tubes much more in depth at a later date. You need to know the terms that are on this slide. And the final slide has medication categories, which we will go over later, but I wanted you to see them now.